Welcome to Mad Medicine with Miss P. I am Miss P. And today we're going to talk about blood pressure. We're not getting too deep into it, not hypertension, because that could be a 2-hour video, just blood pressure. Meaning you need to know how to take it correctly and what to do with those numbers when you get them. Now, if my phone shuts off again and there is a part 2, you need to go find part 2. I got like 171 views on the first video and like 65 on the second video. You're missing the whole thing. There was other vital signs I talked about in the last video, so go check it out. It's not fantastic, but it's information. So, and it's not very long. The second half is like 10 minutes, 15 minutes, something like that. So if it cuts out, let's finish talking about blood pressure. If I don't end the video, then you know it cut out. So real quickly, this isn't going to be a long video, just talking about blood pressure. How you get the correct reading and what to do about it. The most important thing when you go get someone's blood pressure is make sure you have a cuff that fits. If you have a large arm, go get a large cuff. You're going to get abnormal readings when the cuff doesn't fit. It's more or less one of my pet peeves, but I'm not going to get deep into it. But just remember, you have to have a cuff that fits. Anytime a student came to me or they charted a blood pressure of 90/70, I'm like, was the patient alive? Are they talking to you? They were awake, alert. It wasn't like ICU with dopamine running. It wasn't like at a skilled nursing facility with a family in the room and a bereavement cart. Yeah, then you've got the wrong blood pressure. Those two numbers can't touch. You don't perfuse if those two numbers touch. Remember, you have to have some distance between those two numbers, right? So I kind of think of the systolic as that blood pressure, that blood flow coming out of the left ventricle and hitting that aortic wall as hard as it can. That's your systolic, right? So your diastolic is, let's say, kind of when it relaxes down and is kind of as good as it gets and sort of bifurcates and goes to the rest of the body to perfuse. In a sense, it's not exactly, but just to kind of explain it in a way that you can get it. That's kind of what we're looking for. So that top number is the pressure coming out of the left ventricle, and that bottom number is as good as it gets, right? So if they're touching, are you perfusing? If you start and stop, if you take little steps, are you ever going to get anywhere, right? So that those numbers have to have a distance, right? The normal distance is about 40. You may see 30 from time to time. Anything over 40 is hard arteries, right? We talk about that all the time, atherosclerosis. When you see 160/60, 170/70, 180/80, I already know that little old lady is, scrawny, sometimes a normal weight, sometimes even a little heavy set. She's had uncontrolled hypertension for so long that the damage is done. We already have sclerosed vessels. That aortic wall is nice and tight or, hard as a rock. And that first number is going to seem like 160. But if the bottom number is 60, where'd the pressure go? Where did that great pressure go? It changed his mind, made a sharp left, decided not to, got tired and quit halfway down. That's not the way it works, right? So those numbers need to be a distance apart, at least minimum 30. Normal is 40. Higher than that is hard arteries, and we'll see it a lot. Now, when those numbers are narrow and you get like a 130/90, what I see there is like a 26-year-old male, and I'm already kind of wondering, anatomy-wise, what's going on? What is happening in his vasculature that his systolic is normal, but somehow his diastolic is a little higher? We'll talk about that when we get there. But right now, make sure you're getting reasonable readings. Check it again, check it again, check it again. When you get a reading that doesn't make sense to you, or, it's, and I get it all the time. And I say, keep that arm really still. Don't move it for just 1 minute, kind of relax it. And they never do. They always have to lift it or point or touch or something. I'm like, I will hold their wrist sometimes to keep that arm still. That cuff doesn't know the difference between a movement from that muscle or tendon or the actual pump of that vessel. So I say, keep that arm, just let it go limp at your side, keep it really still, and make sure you have a cuff that fits. When I see a scrawny little arm, I'm gonna go use a small adult cuff. I've even used a pediatric cuff on these tiny little people. So make sure you get a cuff that fits. It's really important that you do that. So when we get a reasonable reading, you mark it down, you call it a day and move on, right? When you get an abnormal reading, you have to recognize what's going on. Check it again, change arms, change cuffs, change machines. I've done that before. When you finally get something that is reasonable and it's not, or definite, not reasonable, but definite, and those numbers are not okay, then you need to assess your patient. Are they symptomatic of hypertension or hypotension? And what are you going to do about it? So when you get those really high numbers, and I don't mean 160 over 60, 170 over 70, 180 over 80, 190 over 90, 220 over 80, you're going to see that, and it's okay. May not even be treatable. We'll talk about that later. But make sure you're getting a definite reading, and you change cuffs, you change arms, you've done it manually, whatever you can do, and these are the readings you're getting. Then you have to assess those readings. And anybody that is hypertensive, I don't care why, do something about it. Notify somebody. When I see it in a skilled nursing facility, we get this all the time, right? The nurses are saying like, oh, well, I'm getting ready to give him his blood pressure medication. I'm like, okay, well, last night's blood pressure medication, it isn't working anymore. So he has this, stroke window here, permanent kidney damage window here. That's not okay. Whatever medication he's getting, it doesn't get to wear off for a period of time. And then when you come in, clock in and start giving meds, then it's okay. That's not the way blood pressure works at all. And I'll tell you this again later when we get to it, but uncontrolled hypertension is the root of all evil. I haven't had anybody in the dialysis clinic that didn't have a congenital disorder or an accident or cancer or something that doesn't have uncontrolled hypertension and led them to renal dialysis, or renal failure that they're taking 80 of Lasix twice a day, or such uncontrolled hypertension that it's caused damage to the heart and neuropathy and PVD and all kinds of other stuff, right? So we'll talk about that a little bit later when we talk about hypertension. So before we get into disease processes, we're going to talk about assessment, head to toe assessments and that sort of thing. But just blood pressure right now. Make sure the cuff fits. Make sure you get reasonable readings, and make sure you understand what those readings mean. So if you get 160 over 60 and forever have a patient that's like, oh, that's high for me. I'm like, lady, you live there. You just don't check your blood pressure. Your blood pressure changes with every beat of your heart. So yes, these people can have a fairly normal reading from time to time, but when they do get to 120, chances are that bottom number is like 40 or 50. Still okay for them, but you're going to have a distance in that pulse pressure, those two numbers, because of their anatomy, and you're not changing their internal anatomy anytime soon. So recognize those numbers and what to do about it. Get a cuff that fits, then check it again, check it again, check it again. And if you're still getting some bizarre reading, then you need to do something about it. And recognize sometimes you're going to get different readings out of different arms because of anatomy. So, and we may have guest speakers later on that want to discuss that, certain issues, certain problems in their subclavian vessels, or anatomy-wise, from previous damage, or other issues, disease processes, that you may get different readings from arm to arm. So often I will go from arm to arm and see if I can't get something better. Now, and when we get to patients with mastectomy, you're like, oh, you can't use this arm. And anybody that knows me, that's on my long list of pet peeves. When I get an 86-year-old lady ready for cataract surgery, and she had her mastectomy, which means she had a mass removed, I guess, from somewhere. And she's like, oh, you can't use this arm. I was like, lady, it's been like almost 5 decades. If you haven't developed lymphedema in the past 4.5 decades, you're not going to suddenly develop it now. But they literally don't understand after their mastectomy. Right? Take the T out of Alzheimer's and put it in mastectomy where it belongs. And even after they've had that, if they didn't immediately get lymphedema or within the first 5 years, they're not going to suddenly develop it 4 years later. So what I'll tell them is, if for whatever reason during surgery, if you wake up after surgery and you find the cuff on that arm or an IV on that arm, don't panic, and this is why, and we'll explain it. So you as practitioners or professionals need to understand what that means when we have a mastectomy and lymph tissue is removed, and what that means down the line, what collateral circulation means, and how things aren't because I said so, but actually have a reason behind them. And just because their doctor said that, no needle sticks or blood pressure cuffs in this arm for the rest of your life, that's not a thing. And you need to understand why. Don't do it because someone said it. Don't be afraid to say, can you explain why? I don't understand. What if they were coming in to have a rotator cuff surgery on that arm and they had a mastectomy on this side? We're going to put an IV and maybe even a blood pressure cuff on that side. Maybe a blood pressure cuff on the calf or leg, but chances are the IV is going over here. We're just going to clean with betadine instead of alcohol. That's That's all there is to it. So make sure you're asking questions and you understand that. So that's about all we're going to get into with blood pressure right now, because your hypertension speech will come later, and it's coming. It's a long one. I'm gonna have to see if my phone's been I don't know, hijacked, or I just have to limit my my videos here. But it's really important that you understand hypertension, and that it is never okay to have a diastolic above 89. The only time you can have a diastolic above 89 is when it was just 100 and it's getting better. Otherwise, maybe if someone's asking for your purse in a dark alley, then okay. Maybe if you have a cuff on while getting bad news, that's okay. But when you're getting prepared for planned elective scheduled surgery, it's not a thing. Your uncontrolled hypertension with no symptoms, no less. Yeah, that's not a thing either. When I catch someone at 210 over 114, I say, do you have a headache, dizziness, malaise, diaphoresis, irritability, flushing, anything like that, photophobia? It's like, no, I feel fine. Yeah, that's because your blood pressure is like that all the time and you're just not checking it. Going to CVS with your wife every so often on a day you both have off while having lunch, yeah, that's not how you check your blood pressure. We can all check our blood pressure. It's there. If you can check your blood pressure, that means you're alive and you're capable of checking your blood pressure. What you need to do is test it. Test it when you're anxious, nervous, worried, upset, scared, or in pain. Then you're going to know what your blood pressure really is. And if you don't have symptoms, then you have a problem. And it's called uncontrolled hypertension. And my least favorite ones are the ones that are on antihypertensive medications that took it that morning. Yeah, you might as well have had a handful of Tic Tacs there, bucko, because it's not doing anything. And just because you took them doesn't mean that your blood pressure is under control. Y'all need to be checking your own blood pressure. Unless you're not fond of your kidneys, eyesight, fingertips, toes, whatever. If if those are just a problem anyway and you just want to get rid of them, then you go ahead and live in the 200s over 100s. And that's definite jobs available for my students for the rest of their lives, and me, of course. So you just keep that job security running for us, and keep that blood pressure insane. And if you're lucky enough not to have a hemorrhagic stroke or an occlusive stroke, then we'll be there to take good care of you, if you survive either. So really understand blood pressure and know what those numbers mean, and know when they're okay and when they're not okay. So I tell my students, any systolic greater than 169 needs to be assessed, notified, and treated. Any systolic under 100 needs to be assessed, notified, and treated. Any diastolic under 50 or above 89 needs to be assessed, notified, and treated, which means you're at the bedside. Is the patient okay? Do they have symptoms of hypo or hypertension, which means you need to know what those symptoms are. So find out what those symptoms are, understand them, and then know to recognize them, right? So hypotension would be like poor perfusion, diaphoresis, malaise, pallor. When they're like, I just don't feel good, that's malaise, right? What hurts? I don't know, I just don't feel good. That's because their brain isn't perfusing like it was a little while ago, and they just don't feel well because they're about to pass out. So recognize malaise, diaphoresis, pallor, lethargy. Those are symptoms of hypotension, poor perfusion. Just like, how would you feel if your blood pressure was shooting through your vessels 100 miles an hour, right? You'd be maybe irritable, flushing, maybe diaphoresis. You might even have a bad headache. That's generally our first sign. Photophobia, dizziness, all of those things. So if you've got those symptoms, it's kind of a good thing. That means we recognized it, we found it, we could do something about it. When someone doesn't have symptoms, their body doesn't even recognize that as a problem, which means that's a problem. And it has to be diagnosed. It has to be treated. And it doesn't even have to be about pills. I'm your only pharmacology teacher that's not going to push pills on you. All my friends make fun of me, and I know who you are, but I am a holistic kind of girl. Lose some weight, increase your fluids, watch your salt intake. We can all lose a couple pounds. Go walking, clear your brain. Your brain is the strongest organ on earth, so much so that if I were to talk to you right now about some Sour Patch Kids or those freaking sour Skittles Jessica's feed me, right? Just thinking about it, I'm already getting right here, right? A big mouthful of lemon head. See how you're already starting to kind of feel it right here? That's how powerful your brain is. My husband's resting heart rate was like 52 as long as I've known him. He's been a courier all his life for FedEx and UPS, right? So he has always had this fabulous low resting heart rate, blood pressure of 116 over 70, despite him being a little spaz, right? Just like me, we're both high-strung lunatics. So even with that, he's always had great vitals. He spends a couple years as a corrections officer at the scariest environment imaginable, and he spends my daughter's first birthday in the hospital with chest pain and hypertension. It's your brain. Get your brain right. He leaves that job, does something else, right back to normal. He even put on like 40 pounds at this next job, and still vital signs right back to normal because the stress and the fear of, being stabbed 65 times in the eye by an inmate wasn't there anymore. So he didn't have those hours, he didn't have that stress, and he went right back to normal despite making a quarter of the salary that he used to make years ago when we lived in another state. So now he's back to his currying and dropped all his weight like nothing, and his heart rate and blood pressure are beautiful despite this job being a little stressful too. So get your brain right. But if you have a patient or a family or a friend that has uncontrolled hypertension, you got to do something about it. There's other supplements out there. There's a lot of natural and holistic things. It's not about pills. You don't have to take medication, but you do have to get it right. And I'm always going to be the advocate for uncontrolled hypertension. And every time someone comes in, just Monday, someone had 2 different patients had this like wild uncontrolled hypertension. And they're like, oh, we should go get, you to come talk to them. And I'm like, I don't know that my blood pressure speech is going to make them feel better, because basically what I'm going to tell them is that they probably already have some chronic kidney disease, stage 1, stage 2, something like that. They probably have some swelling in their feet at the end of the day. They've already done like permanent damage to their fingertips and their toes, and their capillaries have, just kind of obliterated under that pressure. So I'm probably not the best person to make them feel better about it, but I might scare them enough to do something about it. I'm not here to be your friend. I'm here to keep you alive, keep you from having these occlusive or, God forbid, hemorrhagic strokes, or just permanent damage, kidney damage, periphery damage, PVD, and all the things that go with uncontrolled hypertension. And that's if you're lucky enough to survive either of these strokes, right? And other things. You can get a PE, you can get an MI. Anything clinging to a vessel under great pressure is going to go pop right off and go through your circulation. And it doesn't care why. So you people out there telling these patients that they're just nervous, you're putting them at risk. When you tell them you're probably just nervous, first of all, stop telling people how they feel. This 86-year-old lady that's had 100 different surgeries, she's not scared of her 9-minute cataract surgery or her 15th ESWAL. She has uncontrolled hypertension, and you telling her that there's a reason for it is not helping her at all. It doesn't matter why, right? What do I always say? Someone comes into the room, punches you dead square in the face, but they have a really good reason. Do you care what that reason is? Because I'm going to go scratch your eyes out. And it doesn't matter why. It matters that. So stop telling people that they're probably just nervous. Or I'll go get your blood pressure medication and we'll take care of that. That's not how that works. There's never a time your blood pressure should be out of control. Now, you get something very stressful, very painful, anything like that, yes, it may shoot up, but then it should come right back down. Your sympathetic nervous system kicks in, it does what it has to do, right? That fight or flight, everything that matters most is increased, right? Better heart rate, better eyesight, better hearing, more blood to your muscles, bronchodilation, everything you need to fight like crazy or run, and everything you don't need is dropped, right? Your periphery, you don't feel anything, you don't feel pain, you don't know until after the knife fight that you've been stabbed. You may lose your bowel or bladder, all the fun stuff, right? Because the things that matter most are increased, the things that matter least are decreased. So that's normal, but once you catch that and your brain says, whoa, hey, that's a little too high, and brings you back down to normal, that's called your fight or flight response. That's a sympathetic nervous system, that's expected. But when you're sitting there for an hour and a half before surgery and your blood pressure is still completely out of control, that's uncontrolled hypertension, and you're at risk of causing permanent damage right here and probably already have some. So nurses, work with me here, okay? We got to get it under control. And when we talk about hypertension and all of our calcium channel blockers, beta blockers, ACE inhibitors, vasodilators, diuretics, all that, we're going to get into that hot and heavy in detail so you understand it. But right now, get a reasonable blood pressure. And if it's not okay, if those two numbers are touching, check it again, unless your patient's comatose, in which case that may be a reasonable reading. They're not perfusing, call the family, let them know what's going on. And if you get some crazy numbers that are too high, let the doctor know that they have uncontrolled hypertension and they're at risk for a stroke and other things, and that needs to be taken care of. And, be an advocate for your patients. And by doing that, you have to recognize what the problem is first. So that's about it. I'll throw in a little pet peeve here. For the love of God, y'all. There's slang, and that's okay. In fact, I just found one of my favorite videos to watch, Brittany Vaughn. If you guys don't watch her, you gotta watch her. She does true crime, and she is freaking hilarious. I love her. And her little slang and her little cute vocabulary is for a reason. But the rest of you, especially your professionals, and I hear this on like the news. Our, meaning our wonderful time together that I enjoy so much, is our, right? R, as in we are going to the movies later, that's A-R-E. So our time together is not A-R-E, it's our time together. And we are going to the movies. Don't get me started on 2, 2, and 2, or there, and there. We'll get there. But our and are different words. Use them accordingly. And as always, forget your failures, face your fears, and follow your faith. All right, y'all. See you next time. Hugs and kisses.